Today's webinar is all about pediatric hearing loss. I hope and we pray that you all are safe and healthy at your respective homes. To begin with, today we are going to learn about what is today's objective. So today's objectives are: why should you care about hearing in children? What do you need to know about devices and treatment for children with hearing loss? How does hearing loss impact the children we work with? And what is your role in minimizing the impact of hearing loss on children? So to begin with, let's first understand and let's go back to our basics. Let's see how does hearing works. The ear. Basically, we all know that there are four different parts in the hearing system. The first is the outer ear, which collects the sound from the environment and passes on to the middle ear. The middle ear comprises of the three tiny bones and tympanic membrane. Through the middle ear system, it then passes on to the inner ear, which has our hearing sense organ, and that is the cochlea. And through cochlea, it reaches the brain via the auditory nerve. As we all know again, that listening starts from 6 months in utero, right? So a child who is in the sixth month of pregnancy will start hearing. And suppose if there is a child who has hearing loss since birth, the child will already have 20 weeks of auditory brain deprivation when the child is born. In addition, their brain is deprived for the amount of time before they are diagnosed and optimally hearing devices fitted. So hence, globally, across the developed countries, hearing loss in babies is now considered as neurodevelopmental emergency. We all know that early identification and intervention of a child who is suffering with hearing impairment will always have good development of communication, language, and social skills. Inversely, if the child is delayed identified and intervened, the child will be associated with lifelong deficits in speech and language, with poor academic performance and personal social maladjustments and emotional difficulties. So let's see what impact does auditory input have on auditory brain development. This applies to a child with hearing impairment and a child also who does have normal hearing skills but is still um is does have deficits of a rich language environment. So suppose if we have a child who is 2 years and is delayed in terms of communication development because of inadequate language stimulation in his home, this also applies to that child as well. Now let's see what happens here. We all know that in our brain there are different lobes which are doing different functioning. Now, as per our history, as per our research, we all know that the temporal lobe of the brain is associated with speech, language, and hearing development, and the occipital lobe is usually for vision development. Now, for a child who has hearing loss, okay, here we can see that the nerves and everything is well developed. But in a child who has hearing loss, there are not enough nerve fibers that are stimulating to the uh, auditory area, right? So what happens then is that the vision takes over the auditory system. We all know that the brain adapts itself. There is neuroplasticity, right? So as you see that whenever there is less stimulation to any part of the brain, the adjacent areas take over. In this case, the vision takes over. And accordingly, the child with hearing impairment will start doing gestural or sign language if the child is not exposed to early auditory access. So, to conclude this slide, we either use this area as early as possible or we just lose it. Going to the incidence and prevalence, we all know that there are about 1 to 3 per thousand infants who suffer from permanent sensorineural hearing impairment. Of this, if The baby who is from well baby nursery, the incidence is about 1 per 1,000, and for NICU babies, it is 10 per 1,000. Now this slide is quite interesting. Now this is about that this is the population, the total population that is suffering from the speech and hearing difficulties. So there are about 642 million people who are suffering with hearing difficulty. Now out of this, near about 278 million are suffering with disabling hearing loss. What do I mean by that? The hearing loss is affecting their communication skills. Of this, 68 million are our babies. And the only population that is being intervened is only about 1,80,000. Isn't that alarming? Yes, of course, it is very alarming. And this figure is much more in the developed countries because they have started applying universal newborn hearing screening program, whereas in India we are still struggling on to achieve that. Coming to the causes of hearing loss, the causes are near about 50% of the hearing loss is attributed to genetic factors, 25% to non-genetic, and 25% to idiopathic. Of the genetic, 70% is non-syndromic and 30% is syndromic. The other factors, the other causes of hearing loss could be touch infection, uh, premature premature birth of the baby, neonatal hyperbilirubinemia, especially when the bilirubin levels are more than 15, ototoxicity, meningitis, birth asphyxia, or other infections. As we see now that the COVID-19 is also being widely researched and is being associated with hearing loss, especially if the mother is the carrier and to the babies as well. So we have started recommending all the babies to undergo at least hearing evaluation at least once if they have the history with COVID-19. Coming to the types of hearing loss, there are majorly two types. One is permanent and the other one is temporary. Permanent will have abnormality of the outer or middle ear, inner ear, and or neural pathways. It can be either in one ear or in both the ears. That means it can be either unilateral or bilateral, and it can range from mild, moderate, severe, or profound degree. In temporary hearing loss, it could be majorly because of the blockage in the outer or middle ear. Blockage could be the simple reason as simple as wax, or it could be because of the otitis media, or it could be also because of the uh, ossicular chain discontinuity. This can also be because of the congenital fixation of the stapes muscle. Now, this can also be unilateral or bilateral. This begins typically with mild degree of hearing loss. And if ignored, this can also increase to moderate or severe category. So if you have any time referred any child for hearing assessment, the audiologist will always try to give you the report in terms of an audiogram, wherein he or she will always mention the degree of hearing loss to be as mild, moderate, moderately severe, severe, or profound category. Now, for a baby who may have, say, mild or moderate hearing loss, uh, for them, we may sound something like this. So you all can identify this rhyme very easily? Yes, so even the baby might be able to identify, but it all depends on the loudness of the speaker. It depends on from how far the speaker is talking and what is the degree and configuration of the hearing loss. For the babies who have greater degree of hearing loss, say about moderately severe, severe or profound degree of hearing loss, we may sound to them something like this. So we are absolutely meaningless when we are talking to them. So what are the ways that the child's hearing is tested? So if you have any time referred a child for hearing assessment, the pediatric audiologist will always assess the child with either one or more tests depending on the results of a particular test. So suppose if we have referred a child for BERA testing and if there is hearing loss, the audiologist will not wait only up to the BERA. The audiologist will have to do other number of tests also like behavioral observation audiometry, impedance audiometry to ascertain the type and the configuration of hearing loss and hence to have proper management strategies for that child. So these are the number of tests that the audiologist will do: impedance, autoacoustic emissions, BERA or behavioral testing. Under impedance audiometry, there are two subtests called as tympanometry and stapedial reflex. For a child who has normal hearing, the audiologist will always get results as type A tympanogram with present reflexes. For a child who is having, say, conductive hearing loss or say has severe to profound hearing loss, the reflexes will be always absent. The other test that is routinely done by an audiologist is OAE test and widely used in hearing screening programs. If the OAs are present, it means that the hearing system is working healthy. Suppose if the OAs are absent, then the child may have either conductive pathology or may have severe to profound or say moderate to profound category of hearing loss. In very rare conditions called as auditory dyssynchrony, the OAs can be present, but yet the child will have difficulty in understanding the spoken language. So what happens in OAE test? We present the sound through the probes and when there is healthy hearing, the echoes are produced back. These echoes are captured by the OAE instrument and hence the results are either pass or refer on the screening results. What happens in BERA testing? So again, there are different electrodes that are put on the baby's one is on the forehead, one is behind the ear, and one is the ground electrode. And the child is stimulated with a sound. Usually the waveforms, the neural pathway is assessed by looking through these waveforms. So suppose if there is any abnormality, the waveforms will look something like this. So this is an example of a normal ABR and this is an example of an absent BERA response. What are the behavioral assessments? So suppose if we get absent ABR or say there is abnormality that is detected in BERA, usually to understand the child's type and the configuration of hearing loss, the audiologist will do one of these tests also depending on the age of the child to ascertain where and what exactly is the problem in the hearing. So to have complete knowledge about the child's hearing system. So suppose if the child belongs to 0 to 6 months, the audiologist will look for the child's physical responses to the sound. Like suppose if there is any sound, if the audiologist presents with any sound, the audiologist will look for any breathing changes in the breathing pattern, changes in the child's head movements, etc. If the child belongs to 6 months to 2.5 years, the audiologist will try to condition the child to attend the stimulus of the sound stimulus by reacting to one of the visual reinforcement. In conditioned play audiometry, when the child belongs to 2.5 to 5 months, the child is tried to condition through a uh, play-based task, something like this shown in the picture. And for a child who is 5 years and above, the audiologist will perform conventional audiometry just like an adult. So, what are the conclusions that are drawn from the hearing assessment? When the audiologist does one or a particular number of test battery, The audiologist will always tell you about the degree of the hearing loss, the kind or the type of the hearing problem, configuration of the hearing loss, and hence make appropriate intervention recommendations. So universally, our dream is one and the same. We all want that our babies should be detected as early as possible, they should be intervened as early as possible, and they should be mainstreamed with their hearing peers as early as possible. And for us to achieve that, the duration of the deafness is very, very critical. We all know that there is a critical period for language acquisition. So, for a child who is born with hearing impairment, the optimal age for intervention is 0 to 2 years. For a child who has crossed 2 years, 2 to 5 years is still suitable for intervention, but the efforts required during the intervention are little longer. For a child who is 5 years and above, the outcomes may be variable except for the progressive hearing loss. This is very interesting that we have started using with our families who are raising kids with hearing impairment. We always tell them that if I have a child who has come to me and is belonging, say, about say 4 months of age, I will still counsel the parents that your child is still in the lower risk of having any effect of hearing loss on their speech and language development. If the same child ignored that counseling and came to me after 2 years, the risk has risen to moderate level. And if the same child who has further ignored and came to us after 5 years again, the risk is very, very high. The brain has stopped or is now slower in learning the new language. So this is another interesting activity that I have arranged for all of us. So let's put ourselves in one of these three zones. If you are doing hearing screening for all the newborns who are coming to you, please applaud yourself that you are into a green zone, that you are really helping us to achieve the difficult dream of early identification and intervention. If you have put yourself into a yellow zone wherein you're only doing hearing screening for only high risk babies, then I really request you to please start doing universal newborn hearing screening at your place. Suppose if you have put yourself into a red zone, I really request you to please start doing universal newborn hearing screening program as early as possible so that we help these kids to develop speech and language and hearing skills as early as possible. So why did I put hearing screening for high risk babies in yellow zone and not in green zone? Because when we are doing hearing screening for only high risk population, we are still missing out on 50% of infants. Yes, you have read it right. 50% of infants are being still missed if you are doing only high risk newborn hearing screening. So what achievements do we have when we do universal newborn hearing screening? USA, okay, a country like USA, which we really look up to, they have reduced the average age of confirmation of hearing loss from 24 to 30 months to 2 to 3 months. Yes, they are now having average age of identification of hearing loss of about 2 to 3 months, which they also had about 2.5 to 3 years. So this they have achieved only by application of universal newborn hearing screening program. As per the CDC data that was produced in the year 2017, so when they were doing only high risk newborn hearing screening, they could identify only 855 babies in the year 2000. When they started applying universal newborn hearing screening program, and that too they have made it mandatory, Yes, they have made it mandatory. No child, no baby is discharged from the maternity home or the hospital without the hearing screening. And because of their compulsion, they are now able to identify 6,337 babies by the year 2016. So that aggressive step they have taken towards eradicating the hearing loss in babies. They could intervene near about 70% of the babies by 6 months, and this they could achieve only because of application of universal newborn hearing screening program. And for them to achieve this, it took 10 years. If we all start now, maybe in another 10 years span, even we may have a data to showcase the world that even India has achieved this data. So we have to also apply the universal newborn hearing screening program. So how they have achieved and what are the protocols that they follow? The same protocol is followed even by us at Aram Speech and Hearing Clinic. We also follow 136 protocol that was recommended by JCIH, that is the Joint Committee on Infant Hearing, in the year 2007. So what do they say? Hearing screening should be done before 1 month. Hearing screening should be done before 1 month. If the hearing screening is failed or has refer results, the diagnosis should be done before 3 months. And if there is confirmed hearing impairment, the intervention should begin before 6 months. In screening, if the results are passed but the baby is still at risk for progressive hearing loss, something like baby had bilirubin levels of more than 15, the baby has hypoxia, the baby had history of premature delivery less than 33 weeks, the baby had very low birth weight, then the baby is still taken for mandatory BERA evaluation by 3 months and is continued to monitor for the next 6 months to 1 year. If the baby is not at risk, no further follow-up is required. But if the baby has refer result, then we do rescreening within 3 weeks. If the baby has passed, again no further testing required. But if the baby has referred on rescreen as well, we do complete audiological and ENT evaluation and management by 3 months. If there is no hearing loss, it is pass. But if there is hearing loss, then audiological management and intervention is done by 6 months of age. Coming to Mumbai scenario, newborn hearing screening is happening at a lot of places, but majorly it is happening only for high-risk babies. Universal newborn hearing screening as per the JCIH protocols is happening at very few places. Here, I would like to congratulate Hiranandani Hospital, which is situated in Powai, and is also being done at a BMC hospital, that is Nair Hospital. Rest, most of them are doing only high-risk newborn hearing screening. This is the data that we have collected from the year 2019, and we have screened near about 668 babies till now, of which 59 babies were referred and 609 were passed. Of 59, we are really honored and privileged to announce that we really have a good follow-up rate, that the babies who came for diagnosis post refer results were 43 and are detected with hearing loss are about 12, of which 5 are with permanent and 7 are conductive. 14 are detected with delayed maturational development and 17 with normal hearing. Now this slide is very interesting, that I have collected data from across the states in the country. What is really alarming is the lost to follow-up cases is really low in a metropolitan city like Mumbai, but the follow-up rates is really good in a remote area like Alibag, that is about 54%, and Kerala, which we consider as one of the best states to implement many uh, good health related policies, so they still have 56 to 59% of follow up rate. This is really alarming, and I really request all my fellow pediatricians and gynecologists and all healthcare who are working with pediatric population to please help us to create awareness and sensitize parents to act as early as possible. This is another interesting skill that we usually administer while we are doing newborn hearing screening in different setups, and these are the responses that we have got from the parents. So, what is really amusing over here is that only 14% of the parents are worried about their baby's hearing. What is really amazing here is that 88% of the families are happy with the professional way that the screening was done. So I really request all my fellow audiologists to do the hearing screening on their own, and please, please do not send any technician to do hearing screening on your behalf, because there are still chances of misinformation or say wrong guidance being provided to these families. So, since we all are professionals, let's do it in the professional way, and families also appreciate that. So, what is the management for this population? So, there are different management strategies for temporary and permanent hearing loss. For temporary hearing loss, if the child is suffering with otitis media, then the ENT specialist will generally prescribe medications. And if the otitis media persists for more than 3 months, then a tympanostomy or grome insertion is done. For a child who is suffering with atresia or say abnormality of the outer ear, then something like Baha technology is being administered. For the child who is detected with permanent hearing loss, the audiologist will usually fit the child with either hearing aids or cochlear implants depending on the candidacy for the each, and they appropriately fit the hearing aids and cochlear implants after number of tests. They do aided audiometry, they do speech evaluation, and they also do behavioral testing with the hearing aids. Mind you, hearing aids or cochlear implant as well is only 10% of the job done. The 90% of the job is still of the therapist. Yes, the hearing aids or the cochlear implants alone will not make the child hear and talk. The therapy is the most important post hearing aid or cochlear implant. So pediatric hearing loss management is an ongoing process. It's an ever-going process. There is no halt in the management. In habilitation, usually the therapist will always work either as auditory, mostly visual, or fully visual. What do I mean by this is the audiologist will see if the child is really young and has good auditory access. The audiologist and therapist will try to fully develop the auditory skills by mostly providing auditory inputs only. If the child is say 3 or 4 years, that is, it is a later intervened child, the audiologist and the therapist will usually use combination of mostly auditory, mostly visual, or even fully visual. So, who are the main management team members? So, the family recipient themselves. Pediatrician, yes, you all play really important role in referring the child as early as possible. Then comes the audiologist, ENT surgeon, neuropediatrician. To neuropediatrician, because the neuropediatrician will help us to identify if there are any comorbidities, or if there are any other associated problems along with the hearing loss. and hence make appropriate referrals to the occupational therapist and physiotherapist. Then there are teachers for the deaf, radiologist, counselor or psychologist to overcome the stigma of hearing loss, occupational therapist, physiotherapist, and speech and language pathologist. So, why do we need a universal newborn hearing screening program? Because we really can't afford not to. We have something very valuable, and that is time. And we all know that the time is the only thing that can create the magic for these children. What is the future of hearing? We are the future for their hearing. And only together we can eradicate the impact of the most common disability in the newborns globally. And I hereby end my presentation by citing this quote. I really thank you for your kind attention and participation. For any queries, please feel free to contact us. And if you have any doubts or anything, please do let us know. We hope you all are safe and we hope you stay healthy. Thank you so much again. And if you have any suggestions for our next webinar, please feel free to tell us. Thank you.